Hello, I'm Dr. Jim Epstein, and I'm at the Chemotherapy Foundation Symposium 2012 here in New York City, and I want to report to you on some of the information that was presented at this year's meeting regarding ovarian cancer. There was a very interesting presentation this morning by Jason Connor from Memorial Sloan Kettering Cancer Institute talking about angiogenesis in ovarian cancer, and I think we're all aware of many of the clinical trials that have been done with the anti-VEGF monoclonal antibody bevacizumab in ovarian cancer. And I want to just review those quickly as Dr. Connor did this morning. There was the GOG 0218 trial, which was one of the larger trials, and this was a 3-arm randomization frontline therapy for resected stage 3 and stage 4 ovarian cancer, randomizing patients to standard carboplatin paclitaxel either alone or with concurrent bevacizumab followed by a maintenance placebo, or concurrent carboplatin paclitaxel bevacizumab followed by maintenance bevacizumab until progression. And the results of that large trial showed that the primary endpoint, progression-free survival, was significantly better in the arm that got carboplatin paclitaxel with concurrent bev followed by maintenance bevacizumab. The difference between the paclitaxel carboplatin arm alone versus the paclitaxel carboplatin with concurrent bevacizumab was not statistically different, but progression-free survival was significantly longer in the group that also got maintenance bev. The other trial, this one in Europe, was the ICON 7 trial. And this population actually included some patients who were somewhat earlier, some very high-risk stage 1 patients, as well as stage 2, 3, and 4 ovarian cancer patients. And once again, the patients were randomized to carboplatin paclitaxel in this 2-arm study with or without bevacizumab, both concurrently and as maintenance until progression. And the primary endpoint in that trial, again, was progression-free survival. There was, again, a statistically significant advantage for the bevacizumab arm with a hazard ratio of 0.81. Now, in recurrent disease, there have been 2 very important trials. The first one, the OCEANS trial, was in platinum-sensitive relapsed ovarian cancer. And in that trial, patients were randomized to carboplatin gemcitabine plus a placebo versus carboplatin gemcitabine with bevacizumab. And once again, progression-free survival was the primary endpoint, and there was a significant improvement in progression-free survival with a hazard ratio of 0.48, indicating a 52% improvement in progression-free survival. That ended up being a 4-month overall improvement in PFS. The second trial in recurrent disease was the AURELIA trial, and this was presented very recently, and this was in platinum-resistant recurrent disease. And as we all know, that's a very difficult population. There are several agents that are used in that situation, including topotecan, pegylated doxorubicin, as well as paclitaxel. So in this trial, the investigators had the choice of which of those 3 agents they would like to use, and then patients were randomized to either the single agent alone or the single agent plus bevacizumab. And once again, progression-free survival was significantly better in the bevacizumab arms with a PFS of 6.7 months compared to 3.4 months without bevacizumab. Again, the hazard ratio in this trial was also 0.48. In addition, the overall response rate was more than doubled in the bevacizumab arms. Now, so these are the trials that really led to approval of bevacizumab in ovarian cancer, and we're still waiting FDA consideration for the approval in the relapse and recurrent setting. Now, Dr. Connor went on and talked about some of the novel agents being looked at for relapsed recurrent disease and patients who are platinum resistant and refractory to treatment. And one of the agents that has been looked at is a combination VEGFR2 MET inhibitor, cabozantinib, or XL184. This is an oral small molecule inhibitor that has been looked at in a variety of diseases, including prostate cancer and lung cancer and other solid tumors. But in ovarian cancer, there was a randomized discontinuation trial in which patients all took cabozantinib during a lead-in period. And then at the first assessment, those patients who had a response continued the study drug. Those who obviously failed and had progressive disease stopped the drug. But those who had stable disease were then randomized either to continue cabozantinib or to take a placebo. And at the end of that trial, 24% of patients had achieved a partial response, and the disease control rate, including significantly stable disease, was 58%. So that agent will be moving forward in ovarian cancer. Another very interesting agent is BIBF 1120, or nintedanib. This is a triple angiokinase inhibitor, and what they mean by that is this drug targets not only VEGFR, it also targets a fibroblast growth factor receptor and the PDGFR. So it hits three separate targets all involved in angiogenesis. There is a large phase 3 trial, the LuME-OVAR-1 trial, of over 1,300 patients that has now completed accrual. The results are probably still perhaps a year away. We'll just have to wait and see. But in this trial, this was for first-line advanced ovarian carcinoma. Patients were randomized to standard carboplatin paclitaxel with a placebo versus carboplatin paclitaxel with BIBF 1120. So those results are anxiously awaited. This is a very interesting compound, and hopefully this oral compound will produce results equivalent, if not better, than what we've seen with the monoclonal antibodies. A second agent that is or a third agent that's under investigation is aflibercept, otherwise known as VEGF trap. And I'm sure, as you're all aware, this agent has just recently been approved for relapse colorectal cancer in combination with FOLFIRI. And it's also being looked at in a variety of other tumors, and it has been studied primarily in platinum-resistant ovarian cancer, especially in patients who had significant ascites, significant malignant ascites. And there have been some phase 2 trials with interesting endpoints that included time to next paracentesis. And we've all had patients like this where paracentesis was the primary method that we had of keeping these patients comfortable. But this trial showed that they were able to significantly increase the time to the next paracentesis with the use of aflibercept. And there have been other trials in which aflibercept has been combined with single-agent docetaxel, and once again, there were significant activity noted. 33 of 46 patients in this phase 2 trial were platinum-resistant, and 25 of the 46 had a partial response. So this is very significant data. What the future holds for aflibercept in ovarian cancer is uncertain at this time, and whether it will move forward into a phase 3 trial remains to be seen. So there were a number of other interesting presentations at this year's meeting looking at some of the genomic analysis in borderline tumors, borderline malignant tumors of the ovary as compared to those that were higher grade invasive. And it demonstrated that there were different mutations seen in these different groups with lower potential for malignant aggressiveness versus those that are more invasive and higher grade. There's work being done in endometrial carcinoma, where we're finally beginning to see some interesting work done and interesting targets identified. So this has been a great meeting. This is always an interesting program here at the Chemotherapy Foundation Symposium. A lot of intensive, brief, rapid-fire presentations covering the whole spectrum of hematologic malignancies and solid tumor oncology. So if you've never been to this meeting, I would encourage you to consider coming next year. I think you'd really enjoy it. So that is it from the 2012 Chemotherapy Foundation Symposium. I hope you will check on our e-learning website for the other programs from this year's Chemotherapy Foundation Symposium. Thanks again for watching.